This is Jerry Hesch. I'm a physical therapist and an orthopedic manual articular therapist, meaning I treat joints throughout the body. Have published a lot on treating the pelvis, and my client flew in from Texas, and her back has been bothering her, or her pelvis on the left side has been bothering her for several years now, and she hasn't been able to get answers. Had a rather clean MRI. Clean x-rays. On the x-rays it looks like there might be a vertical shift in the pubic joint, and that was nice to see because in the clinic we do see this, and that's a rare pattern. It has beautiful hip motion in every direction. Okay, when I come to the pubic bones on the top, there is a distinct step off, and I'm not sure if the camera can see that. If I walk across from the right to the left, I climb up. Do you feel that little step up? Mm-hmm. So let me do that again. I'm coming across, and then boom, it goes upward. Mm-hmm. Okay? But that could be developmental, which would mean nothing. If her pelvis developed that way, it's a non-issue. Okay? So how do we find out if that is an issue? And the answer is we do passive motion testing. So I'm allowing a pinky width for the fibrocartilage in the middle of the joint. She's had 2 children via natural childbirth. And I'm going to come and contact the left pubic bone along the front of it and slightly underneath it. And so I'm pushing up at about a 30-degree angle. It sits at a 30-degree angle, approximately. And so I push and it moves, and I see her head bob, and I'm taking up motion in this joint. And I keep that force. It's about 10 pounds of force. And now I thrust it, and I get a little tiny bit of give and a little bit of bounce, a little bit of recoil. So I can induce motion through that left pubic bone. On this one, nothing's happening. I cannot take up the slack. I'm pushing with a moderate amount of force. There's no movement at all. So this joint does not move on the right side in a vertical direction. Okay? Now, coming to the rest of the pelvis, the ASIS on the right is more anterior than the other side. It's not subtle. Coming underneath it, there's a distinct difference. That's not subtle, in which the right side is lower. And you see that also on the anterior shelves. But again, this is a movement. We're more interested in movement. Is there a problem with her movement? The answer is yes. I cannot take up the slack on this side, and I'm using 15 pounds of force, and then I'm trying to spring it, and there's no movement. On the left side, I can take up the slack, and then I can spring it, and it bounces and it recoils. Okay, and now let's have you lie on your stomach. So on the right side, if I come under her sit bone, I can take up the slack and I can spring it. And the force translates. But I cannot spring it inferiorly. So again, we cannot rotate the pelvis backwards on the right side. On the left side, I can spring superiorly. Nope, I can't. Nope, I can't take up the slack. So I cannot spring that superiorly. From the top, I can take up the slack, and I see the movement translate all the way to her heels, and then I can spring it and I can make it rotate backwards. I just cannot make it rotate forward. So on the right side, I can rotate the pelvis forward. On the left side, no, I cannot. So we named this, based on the movement testing, a right anterior ilium and a left posterior ilium. And some people think this is happening only in the SI joint. In my opinion, it's happening in the entire pelvis. We can evaluate motion going through the SI joint, or blocked movement that does not go through it, but we cannot objectively quantify that motion with hands-on testing. Looked at her sacrum, and her sacrum is symmetrical. There is vertical mobility on each side. When I look, it's symmetrical all the way up. But we have forward bending movement of the sacrum, but we have no backward movement, bending. Okay, there's no ability for that sacrum to move in backward bending, also called counternutation. There's no inferior glide to the sacrum either. Okay, now this type of a movement restriction will usually restrict L5 as well. So I'm finding the PSISs, that puts me at S2. Thumb width higher should be S1, and I should be on L5 also. Above that, just above that, should be L5. So I cannot spring L5. There's no anterior glide spring mobility, and now I'll come up to 4, and now I can take it to slack, and now I can spring it. Okay, so the other thing I want to mention is that her sacrotuberous ligament is right here, and you should be able to indent it slightly, which I can do on the right side. And on the left, it's very tight. I cannot spring that inferiorly. And the sacrospinous ligament is right above that. Okay, so you find the ILA of the sacrum and you walk across a little laterally. And that is very tight. The sacrospinous ligament, which is a transverse, nearly horizontal ligament. And the one on the right side, I can spring. Okay, we looked at her upper body and her neck. The only other thing that I find in terms of a movement restriction is a transverse plane rotation of the first rib. But I think what I'll do is I'll stop filming here now, and I'm going to treat these motion patterns and treat the first rib as well. And I will then film a demonstration of how I treated it, and I will do another film and show all of these tests being repeated. Okay? But what I would like you to do is, can you point where your pain is? Consistent, perfectly consistent with your pain drawing. This curve that follows the PSIS, follows the curvature of the ilium. And the other thing you can do is you can palpate the long dorsal ligament right beneath that PSIS, and I can indent it on the right, and I can slide across it. On the left, it feels very tight, and when I try and spring that ligament forward with my thumb, there's no give. All right, so I'll stop filming and we'll go to work.